Discussion on the general surgical considerations, reconstruction of the anterior cruciate ligament as related to ACL tears. The ACL is a ligamentous structure comprised of parallel fibers of collagen and fibroblasts. The ACL attaches proximally to the posterior medial portion of the lateral femoral condyle. It attaches distally on the anterior portion of the tibia's intercondylar fossa and crosses the interarticular space. Functionally, the ACL restricts anterior motion of the tibia in relation to the femur and resists tibial medial rotation, in addition to providing limited resistance to varus and valgus stresses. ACL reconstruction is normally performed with the patient in a supine position with a leg holder or lateral post. When positioning the patient, the location of the potential autograft harvest site needs to be taken into consideration. Access to the anterior tibia and patellar tendon, anterior medial aspect of the knee, and the proximal portion of the knee joint at the patella's superior pole may all be necessary depending on the autograft chosen. When considering graft selection, have a preoperative discussion about donor site morbidity, loss or reduction of strength and/or function, and the patient's individual postoperative goals. Some surgeons may instead prefer to use an allograft for reconstruction. This decision is typically made prior to surgery through discussion with the patient. Allograft may also be an option for augmenting autograft tissue, or may be used in the event that an autograft harvest is inadequate. Allografts are available as all soft tissue or bone tendon grafts, as well as either non-sutured or pre-sutured. ACL surgery methodology can involve multiple approaches to tunnel creation and graft passage. Some surgeons prefer an all-inside technique, in which the sockets are created independent of one another. Others prefer an anterior medial portal approach and drill the femoral socket independent from the tibial tunnel. Still others may prefer a transtibial approach, in which the tibial tunnel creation guides femoral socket placement. The transtibial approach requires specific positioning of the tibial tunnel in order to come close to approximating the femoral socket, as it cannot be reached across the joint line without changing the location of the tibial tunnel or widening the femoral notch. The femoral socket is created using special offset guides to place the tunnel slightly more anterior and proximal than the native ACL footprint. This results in a more vertical graft orientation, which we will discuss later. In this technique, the graft is introduced via a long tunnel through the tibia, across the joint line, and into the femur. The anatomic femoral footprint cannot be replicated through the transtibial technique unless the position of the tibial tunnel is changed. However, this alters the native tibial footprint. Patient positioning also needs to be considered in an anterior medial portal approach so that the surgeon can drill the femoral socket appropriately. The leg may need to be hyperflexed, or a lower accessory anterior medial portal may be needed. To avoid hyperflexion of the knee that can be difficult for some patients due to body habitus, surgeons can choose to use flexible drills and reamers for creating femoral sockets. In some all-inside techniques, retro drills are used to make short sockets from inside the joint. Specific guides direct those drills to the anatomic footprint of the ACL. This technique allows for precisely placed independent sockets rather than full tunnels. Graft introduction can be done through a standard small arthroscopic incision, allowing the procedure to be done entirely inside the joint, hence the name of the technique. Pass the femoral side of the graft through the portal and into the socket. Then, retropass the tibial side of the graft down into the tibial socket. Following a thorough examination under anesthesia, carefully consider portal placement to ensure access to the ACL and any additional pathology that may need to be addressed. Create standard anterior lateral and anterior medial portals. As mentioned earlier, some techniques may require an accessory low anterior medial portal in addition to other accessory portals to address concomitant pathology such as meniscus tearing or osteochondral injury. Then, evaluate the knee arthroscopically to confirm the ACL injury and evaluate for other associated injuries to the ligaments, menisci, and articular surfaces that need to be addressed during the procedure. In this example, we see a proximal wall avulsion with what seems like good tissue quality. In this case, the patient may be a candidate for ACL repair rather than reconstruction because of the tear location and tissue quality. These factors, described by Dr. Sherman and others, can inform the decision whether to repair or reconstruct the ACL. In an ACL repair, repair the torn tissue with either a suspensory or anchor-based construct. Suture tape augmentation or an internal brace ligament augmentation are often incorporated to protect the repaired tissue while it heals. In cases where reconstruction is necessary, focus next on graft harvest and preparation for autograft procedures, or simply on allograft preparation if this is the chosen graft type. Surgeons can choose from multiple autograft options based on their individual preference, patient activity level and age, and consideration of previous surgeries. After the graft has been harvested, a surgical assistant, if available, can prepare the graft while the surgeon creates the femoral and tibial sockets or the tibial tunnel. Graft preparation depends on the type of fixation the surgeon will use for the reconstruction. Using cortical suspensory or interference screw fixation changes the suture configuration and the type of implant. These fixations are attached to the graft during prep. Studies support a minimal graft diameter of 8 millimeters. If needed to meet the minimum appropriate graft diameter, consider supplementation through graft preparation or the addition of allograft tissue. The ACL's length ranges from 22 millimeters to 41 millimeters. Its width ranges from 7 millimeters to 12 millimeters. Calculate the intra-articular length to ensure appropriate length for the final construct and the necessary amount of graft in both the femoral and tibial sockets. The chosen technique will determine the order in which the tibial and femoral sockets are created. Current techniques allow the sockets to be drilled in any order through guides and retrodrills, which allow for independent drilling. The femoral footprint of the ACL is outlined by the lateral intercondylar ridge, or residence ridge, and the articular margin of the lateral femoral condyle. To find the center of both bundles on the femur, measure the widest distance from proximal to distal on the medial wall of the lateral femoral condyle. Note the point is 43% of the distance from the proximal chondral margin to the distal chondral margin. In the anterior to posterior plane, the radius of the bundles falls 2.5 millimeters anterior to the posterior chondral margin. These measurements help place the femoral socket as anatomically as possible during a reconstruction. In an all-inside technique, drill the femoral socket in an outside-in fashion without violating the far cortex. This ensures suspensory fixation can be used. Document the interosseous length of the tunnel to make sure that there is not a mismatch between the graft length and the available socket length. The socket length can be manipulated prior to drilling based on the placement of the drill guide and the angle at which the socket is drilled. The goal is to have a total length between the socket and intra-articular graft 10 millimeters longer than the amount of graft intended to be inserted. This helps accommodate for any mismatch between the graft length and the overall tunnel length. It also allows for retensioning after the tibia graft is passed and fixed, and the knee has been cycled to remove laxity within the construct. The drill guide can be adjusted to an angle that achieves maximum desired socket depth. The landmarks that indicate the center of the ACL's distal attachment on the tibia are just posterior to the anterior horn of the lateral meniscus in the intercondylar fossa. In the sagittal plane, that is nearly midline on the tibial plateau. If using internal brace ligament augmentation technique, tension the brace independently from the graft. Postoperative bracing and physical therapy guidelines are surgeon dependent. Return to sport typically depends on a return to sport assessment done after completion of a rehabilitation and conditioning program.
Hamstring graft harvest. The hamstring tendon graft can be harvested in a minimally invasive manner using the atraumatic hamstring harvester. In this video, Dr. Steve Jordan demonstrates a minimally invasive harvest of the posterior hamstring graft.
Specifically, we're going to go over the new atraumatic hamstring harvester from Arthrex. As you can see, it has an atraumatic smooth tip, measures 5 by 6 millimeters, which is smaller than most harvesters, will allow us to take less tissue with the tendon, has a nice ergonomic switch or trigger to open and close the harvesting end. You can hear the nice click as it closes. It helps you harvest the tendon.
Thank you for tuning in to Orthopedia for a discussion on clinical applications in the treatment of ACL tears, specifically hamstring graft harvest. The hamstring tendon graft can be harvested in a minimally invasive manner using the atraumatic hamstring harvester. In this video, Dr. Steve Jordan demonstrates a minimally invasive harvest of the posterior hamstring graft.
Specifically, we're going to go over the new atraumatic hamstring harvester from Arthrex. As you can see, it has an atraumatic smooth tip, measures 5 by 6 millimeters, which is smaller than most harvesters, will allow us to take less tissue with the tendon, has a nice ergonomic switch or trigger to open and close the harvesting end. You can hear the nice click as it closes. It helps you harvest the tendon. I prefer the posterior harvesting technique. It's been shown to be faster, smaller incision with less chance of injuring the branches of the saphenous nerve. For the posterior technique, we also need the short, closed harvester to go from proximal to distal to release the tendon off its distal attachment, the tibia. So we also need a 90-degree clamp. And then to deliver the tendon, we use an arthroscopic grasper and fiber tape to control it. Now we'll go over the technique. I prefer the posterior harvest technique because the tendons are so accessible in this area. The technique is quicker, less likelihood of injuring the saphenous nerve. If you prefer the anterior harvest, obviously an oblique incision might be a little better to avoid injuries to the nerve. You can still use the atraumatic harvester, but you might take extra care to release the bands because it's not sharp, and releasing the fascial bands or pulleys up here, take extra care while using an atraumatic harvester. For the posterior technique, I like the patient supine, the leg externally rotated, the foot supported on a small bump. My assistant holds and sometimes just retracts the redundant skin and allows me to palpate. The incision is a little more posterior than you might initially think, but it's right over the tendon. So palpate the semitendinosus tendon and make a small 1-inch to 2-inch incision. I'll make it a little larger today so we can see better. And I usually make a crosshatch over where I felt the tendon, which helps me, and then a little higher to help closure. So we'll make a small incision, dissect longitudinally. You can usually feel the fascia over the semitendinosus. Go ahead and dissect the soft tissue. You can do it bluntly or sharply. And then here we see the fascia, which I'm going to divide in the direction of the tendon. So I always use my semitendinosus as a landmark. It's obviously easier to palpate because it's bigger. It's the furthest posterior. So I always used to remember the PES, sartorius, gracilis, semitendinosus, SGT. Semitendinosus at the bottom. Membranosus is going to be here, and then in a bit we're going to find the gracilis up higher under the sartorius fascia. So I like to clean the tendon, put a right angle retractor around it, take time to identify the tendon again, use a fiber tape looped. I take the loop like this, pull it around, and control the tendon. Clean a little more proximally. So the best way to load this is coming perpendicular to the tendon. I have it controlled with the fiber tape. Take it perpendicular, and this tendon is not very big in this cadaver, so we just go straight up, press against it on a wider tendon, it'll pop in, and then just close it. We then go in line with the tendon to release it. In line with the tendon. As you can see, it slides. Go straight in line with a smooth, firm push. And the tendon releases. As you can see, not much muscle because of the atraumatic harvester. So that's really less bleeding and we think less pain. Have an assistant hold the tendon, and then we deploy the closed harvester quite easily by doing like this and pulling it gently into it. Now this is sharp. We've released our fascial bands distally already. Sometimes I like to take the tendon and wrap it around my finger. Use a Raytech or lap. You must get right next to the leg. That's how this harvester works, right in direct line with the tendon. What I like to do is slowly push. So we slowly push, and I like to work it. Give it a little slack as you work your stripper down there, and then when we get out to the tibia, raise your hand and you can literally pull it right off the bone. So now we have a nice semitendinosus tendon with very little unnecessary tissue harvested, as you can see with the atraumatic harvester. So we've taken the semitendinosus, we move up, we see the semimembranosus fascia here. Sartorius fascia, we divide that and gently lift up. And that's where the gracilis lives. So we have the gracilis, control it with the fiber tape. Again, like to clean the fascial bands approximately, and the distal ones are right here in front of you, so it's not hard to find them. Place the atraumatic harvester perpendicular, close it, in line with the tendon, and harvest.
Discussion on surgical considerations for tears of the anterior cruciate ligament, or ACL. The ACL is a ligamentous structure comprised of parallel fibers of collagen and fibroblasts. The ACL attaches proximally to the posterior medial portion of the lateral femoral condyle. It attaches distally on the anterior portion of the tibia's intercondylar fossa and crosses the intra-articular space. Functionally, the ACL restricts anterior motion of the tibia in relation to the femur and resists tibial medial rotation, in addition to providing limited resistance to varus and valgus stresses. There are multiple ways to repair the ACL. The most common approaches include reattachment to the femoral wall with anchors at the footprint and/or suspensory fixation over the lateral cortex using cortical button and adjustable loop devices. Patient selection is a significant component of success in ACL repair. The two factors that play the most profound role in a successful recovery are the acuteness of the injury and the tear pattern. Older, more chronic tears, and those without a proximal tear pattern may not be recommended for ACL repair, though technique and timing continue to change. In addition, take into consideration factors such as age, activity level, and mechanism of injury. After the decision to repair rather than reconstruct is made, the surgeon should discuss with the patient the potential necessity to transition to a reconstruction with an autograft or allograft if the arthroscopic evaluation indicates a repair is unlikely to be successful. Arthroscopic ACL repair is normally performed with the patient in the supine position with a leg holder or lateral post. Patient positioning is important, as the operative leg needs to be accessible for graft harvest in cases where the ACL is not repairable on examination and the surgical plan is changed to reconstruction. Carefully consider portal placement to ensure access not only to the ACL, but to any additional pathology that may need to be addressed. When performing the suture anchor technique, a low anteromedial portal or an anteromedial accessory portal may be necessary to access the ACL's anatomic footprint and achieve the appropriate insertion angle for the anchors. Following examination under anesthesia, evaluate the knee arthroscopically to confirm the ACL is torn proximally and the remnant ACL tissue is amenable to repair. Evaluate for associated injuries to ligaments, menisci, and articular surfaces that may need to be addressed during the procedure or in a staged manner. Pay attention to the torn ACL and remaining tissue to ensure the tissue is mobile and can be drawn to the repair site. The tissue on the femur and the bony footprint are prepped to create a bleeding bed. Be careful not to resect the remnant or intact fibers from the footprint of the ACL, which is located at the posterior medial wall of the intercondylar portion of the lateral femoral condyle. Place the repair sutures at this point. The decision whether to use a chevron style or a luggage tag style stitch with a suture passer depends on the surgeon's preference and training. To protect and augment the repair, some surgeons add a flat tape suture across the construct. This acts as an internal brace for the ligament and is sometimes also referred to as a safety belt. If using a button and adjustable loop device, place a drill pin through the anterior medial portal. Keep the knee flexed so the pin can be drilled through the center of the prepared ACL footprint. Retrograde drilling can also be used for this step if the surgeon prefers. Load the sutures from the repair through the cortical button. If an internal brace ligament augmentation is performed, load the internal brace sutures through the adjustable loop. Loading the sutures in this fashion allows independent tensioning to be applied through the ACL stump and the internal brace construct. Next, shuttle the repair sutures and cortical button through the 3.5 mm hole and deploy the cortical button. Then, tighten the repair sutures to reapproximate the ACL to the femoral wall while the knee is in full extension. Once adequately tensioned, securely tie the sutures over the cortical button. When using an internal brace construct, pass the suture through the tibia and fixate it independently. In these cases, it is also critical to tension the brace slightly less than the ligament to avoid stress shielding. If the surgeon decides to use suture anchors for femoral fixation, the femoral footprint is prepped in the same way it would be for the tensionable cortical button construct. Drill the anchor holes via the anterior medial portal in a pattern that allows for maximal contact between the torn ACL tissue and the footprint on the femur. Load the repair sutures into the suture anchors and reapproximate the ACL tissue to the footprint. Then, fix the suture anchor to the femur in the previously drilled socket. Close the arthroscopic portals in the normal fashion and place the patient in a postoperative brace to protect the healing ACL. Postoperative bracing and physical therapy guidelines depend on the surgeon. Return to sport typically follows a return to sport assessment conducted after completion of a rehabilitation and conditioning program.